Please to allow all the esteemed delegates who are interested to join on the board now. So this is our second monthly continuing professional development program. Today we are hearing a very current topic, important topic, and many of the physicians are getting phone calls how to tackle this present situation. Now I request Dr. MBR Sharma sir to introduce our esteemed speaker for today, Dr. Alladi Mohan sir. Dr. MBR Sharma sir. I request Dr. KSR Swami sir to introduce Dr. Hari Krishna sir.
Hello, good evening, everybody.
Sir, please, sir.
Good evening, everybody. Dr. Alladi Mohan needs no introduction to the physician's family all over the state and almost all over the country. He is presently professor and head of the Department of Medicine, SWIMS, Sri Venkateswara Institute of Medical Sciences, and Dean, Sri Padmavati Medical College, Tirupati. Apart from that, since his childhood, he has been a recipient of several awards, gold medals, and throughout his undergraduate and postgraduate career.
Sir, I think we will save time for the presentation, sir. You can skip that.
Okay, sir. Thank you.
Dr. Hari needs to be introduced and...
Sir, the second speaker of today's academic activity is Dr. J. Hari Krishna, born on 13th August 1979. He did his MBBS from Kurnool in 2004, Kurnool Medical College, Kurnool, MD General Medicine from Osmania Medical College, DM Critical Care Medicine in 2022, St. John's Medical College, Bangalore. He is currently affiliated as Associate Professor of Medicine, Department of Medicine, Sri Venkateswara Institute of Medical Sciences, Tirupati. He had, for his credit, 16 publications. He is the member of Professional Organization of API, ISCM, member of Index TB Guidelines, WHO, RNTCP, Government of India. So these are the two stalwarts today giving their valuable academic material. Thank you, sir.
Over to Dr. Hari.
Am I audible, sir?
Yeah.
Yeah, I'll start sharing my screen, sir. PPT. Are my slides moving, sir?
Yes.
Yes, sir.
Go slowly.
Yes, sir. Thank you very much for nice introduction, sir. At the outset, I would like to thank APA for giving me this excellent opportunity. Today's topic is critical care issues in COVID-19. So first, what is the need for this talk? So still many active cases are existing world over. According to WHO, which I accessed 4 or 5 days ago, it shows that over the prior 24 hours, almost more than 2 lakh cases were reported world over. So according to Government of India, this site was accessed 4 days ago. There were 2,000 active cases across India. Luckily, we have only 3 active cases in our state, out of which 1 is with us currently. So approximately 5 to 10% of patients require ICU admissions suffering from COVID. And most of the times, these patients are managed by physicians. So we need to know how to manage these patients when there is worsening respiratory symptoms, which is the predominant symptom and cause of mortality in COVID-19. And this will improve our knowledge in managing not only COVID-19, but all other critically ill patients with acute respiratory failure, for example, pneumonia or ARDS patients. So what is, as I have worked as both a resident and a consultant in a large tertiary care teaching hospital, which runs a DM critical care medicine program. At one point in time, we had 100 bedded ICU with almost 80% of patients got intubated and proned. So I would like to share my experience during that period with all of you. So today I'm going to talk about when to admit the patients to ICU, respiratory care of hypoxemic patients with COVID-19, when to intubate these patients, how to manage a intubated COVID-19 patients, and what are the rescue strategies for these patients. So the first question is when to admit these COVID-19 patients to ICU. So it depends upon various factors like individual factors, social factors, personal preferences, and availability of beds. There are no definitive set of guidelines to admit these patients to ICU, but we generally follow when oxygen requirements are more than 6 to 8 liters per minute to maintain oxygen saturation of more than 90 to 92%, when the disease is rapidly progressing, when it is associated with circulatory shock, acute organ dysfunction, and in patients high risk for clinical deterioration, even when the disease is moderate to severe. Severe disease is when respiratory rate is more than 30 and the saturation is less than 90%. So the risk factors for progression to severe diseases are age more than 60 years, cardiovascular diseases, diabetes mellitus, other immunocompromised states, chronic lung, kidney, and liver diseases. When such risk factors are there, we should be more careful in monitoring these patients for worsening of the disease. So what are the risk factors for development of ARDS in COVID-19 patients? So when the age is more than 65 years, presenting with a high-grade fever, neutropenia, lymphocytopenia, elevated markers of inflammation like C-reactive protein, procalcitonin, and serum ferritin, when there are elevated coagulation function related indices such as D-dimer. These patients are high risk to progress into ARDS. These patients should be carefully monitored when they are suffering from hypoxemia. So next question is COVID pneumonia or ARDS, is it similar with other viral pneumonias or is it different from other causes of pneumonia? The answer for this is yes. So then how it is different from other pneumonias? So the peculiar feature of this COVID pneumonia is it is associated with natural response of lung vasculature to intense endothelial dysfunction with a thromboinflammatory state. The abolition of this intense endothelial dysfunction leads to abolition of hypoxemic pulmonary vasoconstriction. The natural response of pulmonary vasculature to hypoxemia is vasoconstriction, so that blood is diverted from the less aerated areas to more aerated areas. In COVID pneumonia, this vasoconstrictive property is lost. This leads to continuous supply of blood to the non-ventilated or less ventilated areas, which leads to increased shunting. And microthrombus formation in the vasculature leads to increased dead space ventilation. These two features are peculiar to COVID-19 pneumonia. So it has been proposed that based on the progression of the disease, there are two primary phenotypes have been proposed. One is type L, another one is type H. So type L pneumonia or ARDS is associated with low resistance, low ventilation perfusion ratio, low lung weight, and low recruitability. And type H disease is characterized by high elastance, high right to left shunt, high lung weight, and high recruitability. So our ventilatory strategies depend upon on which stage the patient is, whether it is type L phenotype or type H phenotype. Most of the times the patient progress from type L phenotype to type H phenotype. So the post-mortem examinations of lung have shown that In type L disease, on left side, you are seeing a CT scan, which is the typical CT scan of a COVID-19 patients in type L stage, where on the right side, the histopathological examination shows numerous lymphocytic infiltration, the thin arrow, and the damage to the type 2 pneumocytes. It's suggestive of lymphocytic pneumonia. It corresponds to L type of the disease. Then when it comes to H type, it is full-blown ARDS. The histopathological examination of the lung shows organizing pneumonia within the alveolar ducts. This thin arrow shows organizing pneumonia within the alveolar ducts and fibrin balls. It constitutes acute fibrinous and organizing pneumonia. So this is the reason in subacute form, this organizing pneumonia is steroid responsive. This is the reason for steroid responsiveness of the COVID pneumonia. For example, in H1N1 influenza, in patients with ARDS, steroids are not indicated. In fact, it is associated with increased mortality, but it is not the same case with the COVID-19 pneumonia. The reason is this: it is associated with organizing pneumonia, which is a steroid responsive pathology. So the understanding of this pathophysiology is required to maintain the adequate and appropriate mechanical ventilation for these patients who are suffering with COVID-19. So what are the respiratory care for these patients when they are suffering from hypoxemia? It starts with low flow oxygen delivery systems, either with a nasal cannula, oxygen face mask, NRBM, or it could be high flow system with a HFNC, non-invasive ventilation, or invasive mechanical ventilation. There are some rescue therapies, for example, prone ventilation, neuromuscular blocking agents, pulmonary dilators, and extracorporeal membrane oxygenation. In the coming slides, we are going to discuss about when to apply these various strategies. So the oxygen targets in COVID pneumonia patients, according to World Health Organization, it should be maintained more than 94% during initial resuscitation, and more than 90% is enough to maintain the oxygenation. So for all practical purposes, it is to be maintained around 90 to 96% in patients with COVID pneumonia. So whenever we see a patient with COVID pneumonia with hypoxemia, the initial strategy is to start supplemental oxygenation with the low flow systems via nasal cannula. So for patients who has higher oxygen requirements, more than 6 to 10 liters per minute, what is the next option? This is the most presentation. So the option A is to increase the oxygen flow or to start the patient on non-rebreathing mask. Option B is to change to non-invasive modes. Option C is to start invasive mechanical ventilation. So what is the answer? So in practice, most of the times we see the option A. So whenever there is increasing oxygen requirements, we are going to put the patient on non-rebreathing mask. Is this practice correct or not? We will examine it with the evidence. So there is one study, a randomized control trial, multi-centric trial published in JAMA in 2021, which was done on almost 700 patients. They were randomized either to high flow oxygen or to standard oxygen. Standard oxygen means when the oxygen requirements flow is more than 10 liters per minute, and the primary outcome was mortality. They found there is no significant difference in the mortality, but what they did find is there is the Kaplan-Meier curve shows with the standard oxygen therapy compared to high flow oxygen, there is increased need for mechanical ventilation with standard therapy. So high flow oxygen definitely decreases the need for intubation when it is started appropriately. So the same question with the evidence now. What is the next option when patient is requiring higher oxygen flows? So the answer is B. It is change to non-invasive modes rather than increasing the oxygen flow or starting the patient on non-rebreathing masks. So upper limit, we can take it as patient requiring more than 6 to 10 liters per minute. So then if it is non-invasive modes, what non-invasive mode should be used? One could be HFNC and other option could be NIV. So which one to choose? So HFNC versus NIV. So the available clinical data do not clearly demonstrate the benefit of one modality over the other modality. So NIV is usually preferred in patients with a comorbidity for which there is a proven efficacy of NIV. For example, acute hypercapnic respiratory failure, exacerbation of COPD, acute cardiogenic pulmonary edema. In these two conditions, when it is associated with COVID pneumonia, we can use NIV. Otherwise, in the absence of such comorbidities, either modality is acceptable. So HFNC is usually preferred as it is more comfortable. Now, most of us are comfortable in initiating a patient on HFNC. I used to see before COVID in the ICU at one corner HFNC mission, which I never used. But COVID made us to use this HFNC and it made us to find the ease of use and the benefits of using HFNC. So patient can continue to converse and eat while on HFNC, and HFNC is associated with fewer adverse events. So in these situations, when there are no definitive indication for associated conditions with NIV, HFNC is preferable. Then once we start either HFNC or NIV, we cannot just leave the patient. Once you are starting non-invasive modes of ventilation means you are ready to intubate the patient in case if he worsens. So how to monitor these patients on non-invasive ventilation modalities? For example, if patient is on HFNC, ROX index can be used, which is oxygen SpO2 divided by fraction of inspired oxygen divided by respiratory rate. This index is called ROX index. If ROX index is more than 4.88 measured at 2 hours after starting HFNC initiation, it is associated with lower risk of intubation. Then predictors of HFNC failure are ROX index less than 2.85 at 2 hours or ROX index less than 3.47 at 6 hours. This ROX index is very easy to calculate. So another easy way is whether our HFNC is doing benefit to the patient or not is once after starting HFNC, then we can appreciate that improvement in oxygen saturation and decreased work of breathing. This work of breathing is more important. We can identify based on respiratory rate and depth of respirations. Even after starting HFNC, if there is no improvement in the work of breathing, that means this HFNC is not going to work. So in patients with COVID-19, this ROX index has been validated, and the studies have showed that a ROX index of less than 5 measured between 2 to 6 hours after initiation of HFNC was associated with a HFNC failure. If the patient is started on NIV, in such situations, NIV means non-invasive ventilation with a face mask, then Haaker score should be monitored, which stands for heart rate, acidosis, consciousness in the form of GCS, oxygenation in the form of P/F ratios, and respiratory rate. A Haaker score of more than 5 at the end of 1 hour of starting NIV, it predicts the NIV failure. So once we start either HFNC or NIV, we cannot continue these patients in spite of its response to NIV. We should carefully monitor the response of these patients to NIV. If there are any chances of failure of NIV or HFNC, then better to proceed for intubation rather than leaving these patients on those non-invasive modalities. So in situations when patients are on non-invasive ventilation, if there is a sudden rise in oxygen requirements, the possibilities could be one, pulmonary thromboembolism, which is common in COVID-19 patients. Another one is myocardial infarction or acute cardiogenic pulmonary edema or pneumothorax. As we know, COVID-19 involves peripheral areas of the lung which are subpleural. When patients are on HFNC or especially NIV, positive pressure ventilation, these patients are more prone to develop pneumothorax. So when the patient is on NIV or non-invasive modes, whether next question is whether to continue the same thing or to intubate the patient. So when to initiate invasive mechanical ventilation. Delaying intubation until the patient has features of impending respiratory arrest. For example, use of excessive accessory respiratory muscle, presence of paradoxical breathing, in spite of being on maximum non-invasive support, is potentially harmful. So patients on non-invasive support should be monitored carefully for the failure. Whenever there are signs of failure, these patients should promptly and appropriately intubated. So why is this harmful? Why can't we continue these patients on NIV or HFNC rather than putting the patient on mechanical ventilation if there is no decreased work of breathing with these non-invasive modes? So the reason is patient self-inflicted lung injury, which is called as PCLI. So the evidence for this PCLI is the outcome of intubated patients who failed NIV is poor. This is obvious. Somebody is failing NIV means the disease is severe, they are failing. But the other thing which is more important is when these patients were randomized to continuing NIV or when there is NIV failure is identified and these patients are intubated at appropriate time, they fare better. So early identification of NIV failure and intubation has improved outcomes. So an average tidal volume of 10 ml per kg or above of the predicted body weight on NIV is a predictor of NIV failure. These observations indicate that PCLI may occur in patients with NIV when the disease is severe and the efforts are vigorous. So when patients are these non-invasive modes with increased work of breathing, these patients should be better intubated as early as possible. So what is the reason for this PCLI? Is increased lung stress. So on the right side, when patient is spontaneously breathing, the transpulmonary pressures are very high with the similar airway pressure. In both things, on the left side, it is muscle paralysis on mechanical ventilation. On right side, spontaneously breathing patients. In both these, airway pressure is 20 centimeters of water, but see the transpulmonary pressure. It is 25 centimeters of water in spontaneous breathing patients. It is only 15 in mechanically ventilated patients. So in these patients, the transpulmonary pressure is very high. It is not high in spontaneously breathing patients who have normal work of breathing. When work of breathing is very high, the transpulmonary pressure increases, which causes lung stress and lung injury. Especially when heterogeneous involvement of the lung is there, for example, in COVID ARDS, these forces generated by the diaphragm are not uniformly transmitted to all over the lung. Most of the times they concentrated around the injured lung, which leads to increased transpulmonary pressures, increased stress and increased local trauma. So vigorous spontaneous efforts in severe lung injury leads to increased transpulmonary pressure, high local negative pressure in dependent non-aerated lung, which leads to increased local lung stress, which leads to volutrauma, atelectrauma, biotrauma and barotrauma, which combined together is called patient self-inflicted lung injury. So the message from previous 3-4 slides is that when patient is on non-invasive modalities of ventilation, these patients should be carefully monitored for NIV failure. If NIV or HFNC is not decreasing the work of breathing or requiring very high flow rates to maintain oxygen or oxygenations are rapidly worsening, these patients should be intubated. Undue delay in initiating invasive mechanical ventilation in patients with high work of breathing is associated with poor outcomes. So next question is when to initiate mechanical ventilation. So patients with rapid progression over hours, patients with a persistent need for high flows or FiO2s, for example on HFNC 60 liters per minute with a FiO2 of 1. These patients should be better intubated as early as possible rather than delaying intubating these patients. Patients with evolving hypercapnia, which indicates in a hypoxemic respiratory failure, hypercapnia indicates respiratory muscle fatigue, then increasing work of breathing, decreasing tidal volume, worsening mental status because of increasing PCO2 levels, increasing desaturations. And patients with hemodynamic instability, these patients should be intubated as early as possible at appropriate time. So next question is how to manage a patient on invasive mechanical ventilation. As I already discussed, there are two types, type L and type H. When we intubate a patient in type L stage, which is associated with low elastance, that means high compliance. Compliance is very good and there is low recruitability. So the ventilator strategy in these patients should be high tidal volume, which includes 7 to 8 ml per kg body weight. It is to avoid reabsorption, atelectasis and hypercapnia due to limited tidal volume induced hypoventilation. And these patients require low PEEP as the lung is not that much recruitable. So low PEEP means some 8 to 10 centimeters of H2O. If we provide more PEEP, it causes over distension of the normally aerated lungs, which leads to compression of the capillaries in between the alveoli, which leads to decreased blood supply to the aerated lung and which leads to increased shunt. If we intubate the patient in type H stage, which is characterized by high elastance and high recruitability, the ventilatory strategy would be low tidal volume ventilation, that is 6 ml per kg body, ideal body weight, high PEEP, which ranges from 12 to 16 centimeters of water. Plateau pressures should be maintained less than 30 centimeters of water and driving pressure should be less than 14 centimeter. We can get plateau pressure by giving inspiratory pause on mechanical ventilation, and driving pressure is the difference between the plateau pressure and the PEEP that we have applied. It should be less than 14. This is called lung protective ventilation. Then coming to rescue therapies, when we are unable to maintain adequate oxygenation levels around at least 92 to 94%, even with maximum ventilatory supports, then we need to move on to rescue therapies. These include, one is prone position ventilation, second one is neuromuscular blockade agents, third one is pulmonary vasodilators, fourth one is extracorporeal membrane oxygenation. So neuromuscular blocking agents decrease the asynchrony and decrease the patient ventilatory efforts, which leads to uniform distribution of the ventilation, leads to increased oxygenation levels. So the trials have clearly showed that neuromuscular blockade initial 48 hours of mechanical ventilation in severe ARDS patient improves the outcome. Pulmonary vasodilators like inhaled nitric oxide or inhaled epoprostenol cause pulmonary vasodilatation and it increases the oxygenation levels by 10 to 20 mm of Hg. And in patients with third one is extracorporeal membrane oxygenation. And among all these, easiest thing and we can apply in any setting is prone position ventilation. What we need is a little bit of experience in proning the patients who are on mechanical ventilation. So this slide shows a patient with severe ARDS on prone position ventilation. It is labor intensive. We need at least 6 to 7 persons to prone a patient on mechanical ventilation, but it is not resource intense. What we need is only 2 pillows under the chest, 2 pillows under the pelvis and 1 pillow under the legs. We should maintain adequate gap between these 2 pillows so that abdomen is freely mobile and it is not touching the bed. If the gap is not so much and we put pressure more on the abdomen, lungs cannot take the air and inspiratory pressures will increase. So what are the indications for prone position ventilation? When P/F ratios are less than 150, better to prone these patients when there are no contraindications. The definitive absolute contraindications were spinal instability, raised intracranial pressure, sternotomy within 2 weeks. If these contraindications are not there, most of spinal instability and sternotomy, most of the things we see in patients with trauma. COVID patients less likely to have trauma. So raised intracranial pressure is also less likely. So most of the patients are eligible for proning when P/F ratios are less than 150. So next is, these patients are more likely to respond when we prone these patients in early phases of ARDS. So the duration of proning is at least 12 to 6 hours per day. When to discontinue this proning? So when P/F ratios are more than 150 mm of Hg for at least 4 hours, after last proning session, then we can discontinue proning. And complications associated with proning are dislodging endotracheal tubes, pressure sores on the face and chest, dislodging vascular catheters or drainage tubes, retinal damage, and vomitings. Vomitings leads to feeding intolerance. So benefits of proning clearly outweigh the complications associated with proning. It improves the oxygenation. So among the 4 rescue methods which we have discussed till now, proning is the easiest one. So there are some specific precautions which is required to be taken in COVID-19 patients. We need to maintain tight seals in all ventilatory circuits and equipment. We need to maintain adequate ET cuff pressure between 20 to 30 centimeters of water to prevent the leakages. And we should avoid unnecessary disconnections with the ET tube. Inline suction catheter devices like closed suction catheter system should be used. If disconnection is necessary, the ET tube should be temporarily clamped during disconnection and should be declamped. Then better to ventilate these patients in airborne isolation room if it is available. So the take-home message of respiratory management of COVID-19 patients is start non-invasive modes of ventilation in patients with higher oxygen requirements, that is more than 6 to 10 liters per minute. If we are planning to start non-invasive modes, which one to be used, HFNC or NIV? Clearly, there are no clear indications for NIV like acute hypercapnic exacerbation of COPD or acute cardiogenic pulmonary edema. HFNC is preferable because it is comfortable to the patient. Patient can converse, patient can eat while on HFNC. Once we start non-invasive modalities of ventilation, we should carefully monitor these patients for failure of non-invasive modes. If there is a failure of non-invasive modes, which can be indicated either by a ROX score or Hawker score or bedside with the experience, we can clearly perceive after starting of these HFNC or NIV, there is no adequate response in terms of work of breathing, then these are not going to help the patient. In such situations, do not delay intubation in patients with high work of breathing in spite of maximum non-invasive supports. These patients should be intubated and started on invasive mechanical ventilation as soon as possible. Then individualize the ventilator settings based on the stage, whether it is L-type or H-type. In L-type, we need to give a little bit more tidal volume and a less PEEP. In H-type, we need to ventilate patients with low tidal volume with high PEEP. Prone position is, if indicated, we should prone these patients at early stages of the disease. During that stage, lung is more recruitable. So with this, I stop here. I thank everyone for your patient listening. So
thank you, Dr. Hari Krishna Garu, for your excellent coverage of topic and at what time you are supposed to escalate your management and various aspects of ventilation. And thank you. And any delegates or postgraduates want to interact with the speaker, 1 or 2 questions? Anybody want to interact with the speaker? So if there is no questions asked, we will move to the next topic by Dr. Alladi Mohan Rao, sir.
Sir, one comment on the phenotypes of ARDS of COVID-19. Initially, when these reports came in, it appeared to be a clear-cut line. One could easily distinguish between the phenotypes. But gradually, as more data emerged, there is a blur between the two. While it is hypothetically easy to quantify them as the 2 different phenotypes, at the bedside, it's not that easy. What, Dr. Hari?
Yes, sir. Yes, sir. That's why ventilatory management in these patients should be individualized. So we should, whenever we are adjusting PEEP, we should assess whether our PEEP is going to help the patient or not, based on oxygenation levels and recruitability. Recruitability of lung with the PEEP can be assessed by assessing the plateau pressures. Once we increase the PEEP from one stage to other stage, it takes some time for it to act. For example, half an hour. After half an hour, we should assess the compliance of the lungs, whether it is improved or not. If the PEEP is going to benefit the patient, there will be increase in the compliance. If there is no increase in the compliance, then there is no point in increasing PEEP unnecessarily. It will worsen the respiratory parameters.
Can I stop?
Yes,
Dr.
sir.
Ramamurthy?
Ramamurthy
See,
garu.
we can take the ABG at one time or other. Why not we see the ABG? There is hypercapnia, PSA would increase it. Then automatically we can increase the tidal volume, increase the PEEP, increase the FiO2 by mechanical ventilation. ABG should be taken into consideration, what I feel.
Definitely, sir. ABG should be monitored at regular
Should be
intervals.
monitored. Thank you, sir.
Thank you,
That's what
Ramamurthy
in-
garu. Thank you, Alhad Mohan garu, for your nice contributions. Sir, anything else, sir? Shall we move to the second topic?
Yes, sir. Yes, sir. Yes, sir.
Thank you, madam.
Dr.
Alhad
Hari,
Mohan, sir.
if you unshare your screen, I'll share my screen.
Yes, sir.
I hope my screen is visible to all. The topic given to me today has been to speak briefly on the COVID-19 variants and COVID-19 vaccination, the current evidence. As we are moving forward into the dying minutes of a disappearing day, it would be a task to come between you and your dinner. I'll try to keep it simple and crisp to first address what constitutes a variant. Why I am worried is I have in the last 3 or 4 postgraduate examination of MD Medicine, General Medicine, postgraduates are unaware of what constitutes a variant. How is a variant defined? What is a nomenclature is also important. Since there are postgraduates in this group, I would like to recapitulate a very famous story. If you remember your basics of Ramayana, the kidnapping of Sita, this is how it happened, and that's how she was taken away. If we see carefully, this got transformed to this. So, shapes shifting or variants or all the viruses, including the SARS-CoV-2, where the change occurs over a period in time. While sometimes these changes may affect the virus's properties, such as how easily it spreads, the associated disease severity, or the performance of vaccines, therapeutic medicines, diagnostic tools, or other public and social health measures, but it's not always like that. So we should know to understand. So one day the newspaper carries XBB 1.1.5. So what does this refer to? The established nomenclature systems for naming and tracking the SARS-CoV-2 genetic lineages by these 3 systems are current, and they will remain in use by scientists. So some overlapping or some nomenclature confusion is inevitable. However, to assist with public discussions of the variants, the WHO had convened a group of scientists from the WHO Virus Evolution Working Group, which is called the Technical Advisory Group on Virus Evolution, and the WHO COVID-19 Reference Laboratory Network. These representatives, etc., they have evolved the easy to pronounce, non-stigmatizing labels. When it came to calling a New Delhi strain of a certain bacteria, there was no stigmatizing. India can be stigmatized. But when it comes to stigmatizing China, there is a psychological problem. So at the present time, the expert group convened by the WHO has recommended the using the letters, the Greek alphabet, alpha, beta, gamma, delta, which will be easier and more practical to be discussed by the non-scientific audiences. When using this naming scheme and referring to the genomic sequence of SARS-CoV-2 identified from the first cases, the term index virus should be used. We all, I think, definitely remember the Delta wave. And now we are presently concerned with the Omicron variant. What is a variant of concern? The working definition of a variant of concern is a SARS-CoV-2 variant that meets the definition of a variant of interest and through a comparative assessment has been demonstrated to be associated with one or more of the following changes at a degree of global public health significance: increase in the transmissibility or detrimental change in COVID-19 epidemiology, or increase in virulence or a change in the clinical disease presentation, decrease in effectiveness of public health and social measures or available diagnostics, vaccines, or therapeutics. So as on date, as listed at the WHO website, what are the currently circulating variants of concern? Variants of concern. These variants are circulating since November 2021 in more than 48 countries. The WHO label for this, as we have discussed previously, is Omicron. The Pango lineage is B.1.1.529. This includes the BA1, BA2, BA3, BA4, BA5, and the descendant lineages. These descendant lineages should be monitored as distinct lineages by the public health authorities, and comparative assessments of their virus characteristics should be undertaken. So the one variant has been making a lot of news, which is called the XBB.1.5. If you see the Omicron lineages, which is sitting here, the earlier ones alpha, beta, delta, and gamma. The XBB.1.5 is a fusion or a recombinant of two different BA2 variants, which are BA2.10.1.1 and BA2.75.3.1.1. So how does this fusion occur? This is the molecular mechanism, quite complex, but it would suffice to understand that these two fuse to create this XBB variant. We have XBB, XBB.1, XBB.1.5. Now, what is the importance of these emerging variants? In this study recently published in the Lancet a few days ago, antigenic mapping of the emerging SARS-CoV-2 Omicron variants BM.1.1.1, BQ.1.1, and XBB.1. The take-home message from this is the newer versions of the virus are escaping the antibodies generated by the previous versions and from the vaccines. How does it look? If you look at in this picture, circle is a variant and a square is the antibody panel against which it has been tested. If you see the XBB.1, the circle here is located far away from all the antibody panels. Similarly, there is the highest immune escape noticed with the XBB.1 and XBB.1.15 variants. So there are key mutations which occur when we look at the genetic diversity in the spike of Omicron BA1, BA2, BA5, BQ, and the XBB.1 isolates. So now the variants are emerging. It is said the XBB variant escapes the antibody panels. That is why the COVID-19 cocktail, which came up with a big hue and cry, is presently neither useful nor necessary because the current variants are escaping. So what is the relevance of this information to COVID-19 vaccines in India? I want you to look at one of the old pictures which came in 2020. It still holds good. You have a person who is not vaccinated on this side, and you have a group of people with vaccine. Please note, the vaccine is designed to protect from severe disease. Vaccine does not change transmission. By taking vaccine, one should not imagine that disease transmission is averted. For a person who has not been vaccinated, about 1/3 are having asymptomatic infection and about 80% have mild disease. But if the vaccine which reduces the disease severity but not infection, which is the aim of most vaccines, are taken, the asymptomatic infection or mild disease predominates. Severe disease is practically not seen. So what is the situation with regard to the protective effectiveness of previous SARS-CoV infection, hybrid immunity against the Omicron variant, that is the XBB, XBB1, and severe disease? In a systematic review and meta-regression, it was shown that all estimates of protection had waned within months against reinfection, but remained high and sustained for hospital admission or severe disease. So individuals with hybrid immunity had the highest magnitude and durability of protection, and as a result, they might be able to extend the period before booster vaccinations are required compared to individuals who have never been infected. In India, the workforce that is driving the COVID is the hybrid immunity, as opposed to other countries. China had a total lockdown policy wherein there was no chance for a hybrid immunity to emerge. That made them all vulnerable, and that's what we are seeing both in the media and in scientific journals. So as there is a significantly higher occurrence of hybrid immunity, the gap between the need for the next booster is much longer in India. That brings us to the key questions. If you look at the story of COVID-19 vaccination, the first dose was given in Jan 2021 to the healthcare workers. This was followed by the administration of another dose that was gradually given from the healthcare workers pool to everyone across the country, including children. Thereafter, in the beginning of 2022, the precautionary dose was introduced. This is not the DPT third dose to be given 1 month apart. We really don't know the risk-benefit ratio of vaccination. We really don't know how safe it is to give multiple doses. India has seen a very peculiar situation. After the second dose, most doctors, most physicians went ahead with an unofficial third dose because of emotion-based medicine, not evidence-based medicine. The permitted wastage of vaccine is 5 to 7.5%, and that 5 to 7.5%, I personally feel, was never wasted, but was used by doctors in a panic as a third dose because they were doing it in the US. Now, after the precautionary dose, I am pumped with questions. Sir, I am going to Dallas. There they are giving vaccine, sir. Should I take fourth dose? Sir, should I refuse taking it? Sir, I was in the US. They have already given me fourth dose. Now I am eligible for precautionary dose in India. Can I take fifth dose? So in this background, as on date, based on the current evidence, do we need more doses? US is giving fourth dose. Should we take the fourth dose? As the evidence stands, given the variants that are circulating in India and given the hybrid immunity, which is a unique feature in India as opposed to the other Western countries. The time is not yet ripe for yet another dose of COVID vaccine for those who have taken the first dose, the second dose, and the precautionary dose. Will we not need it? Will it become an annual vaccination like influenza? We don't know yet. Time will have to give the answer. What I have spoken today may change tomorrow morning, but this is the evidence that's available today. Till then, what is the way forward? The two unpleasant things, that is keeping a distance and using a barrier. Using a barrier when you are out of your biological bubble, when you are in a crowd, when you are in a wedding, funeral, mall, conference, wherever you are, please mask yourself to protect yourself from severe, life-threatening, critical disease. I hope all the genealogy and the terminology of vaccines has not messed up thinking. But the take-home message is, yes, new variants are emerging. The new variants, whether they are highly transmitted, whether they are killing people, we don't have hard data. Whether the vaccines will protect against these, again, it's wishful thinking. These variants were not there when those vaccines were made. So the question is upfront a redundant question, but many of the new emerging variants, especially the XBB series, are escaping the antibody cocktail. So a big hue and cry last year around same time about the antibody cocktail, which was very popular in India. Suddenly it came to be known to spend 1.5 lakhs and it doesn't protect you. It's the same case everywhere in the world. I conclude here. If you have any queries, questions, please feel free to shoot.
Thank you, sir. Thank you. As usual, it's a wonderful session. I think SWIMS has vast experience of treating thousands of COVID patients, particularly Dr. Alladi Mohan sir needs no introduction, and he has cleared all the questions what I have asked him before giving the topic. So thank you very much, sir. And I appreciate Dr. Hari Krishna for again joining SWIMS after completing his DM and taking care of all the critical cases. Thank you very much. Now the house is open for discussion and expert comments by our seniors. Sir, Dr. I.V. Rao sir, Dr. Ishwar sir.
Dr. Ishwar, a very good talk by Dr. Alladi Mohan as usual, but I have a little sharing of a small point with the audience. That is the boosters for other influenza is different every year, but as far as this is concerned, we'll have a booster fatigue, a phenomena which has been raised of late. Any comment from our esteemed Professor Dr. Alladi Mohan?
Sir, this is an area of contention, sir, because is booster a boon or a bane? It's a matter of debate. And,
Yes, sir.
it is one thing when I spoke with my friends in WHO, they were telling that India's overall, the hybrid immunity is what is keeping it safe.
Yes, sir.
Countries.
It is a boon for us and bane for the origin of virus country.
They deserve it, sir.
It's a wonderful lecture, sir.
But in this context, our neutralizing antibodies are nothing to do with our Indian immunity, is only a cell-mediated CD8 as of understanding presently in a good way. So, I agree, sir.
Sir.
Yes,
Dr.
thank you,
Mohan,
sir.
Yes, madam.
Sir is asking about the cell-mediated immunity and the neutralizing antibodies.
They
Sir,
are useless.
Sir, neutralizing antibodies are not to be monitored to administer either a booster or they don't serve any therapeutic purpose. They only serve epidemiological mapping purpose. We should
Thank
not
you.
be guided. People used to ask me, I have tested my antibody, the titer is so much, should I take booster? Should I take vaccine? They are not designed, or they are not.
That's why you have to dispense away with that method of estimation.
Yes, sir. True.
Thank you.
Dr.
Thank you.
Ramamurthy.
Wonderful.
One second, sir. Alladi garu. Are there any long-term immunological problems, diseases rather, like autoimmune diseases, which are, exacerbated by these vaccinations?
Sure, sir.
I learned from my other colleagues that diseases like lichen planus and other diseases are being exacerbated, and new diseases also are happening in the country.
Sir, there is a whale of data, quite scary data, which is pouring in with regard to the safety. Safety of the vaccine is still not established, sir. Initially, we had hesitancy, then we had a panic for the vaccine, and now we have a irresistible, uncontrollable urge to boost our immunity by repeated vaccination. Any vaccine has a downside, and definitely only time can answer your question, but we are seeing more of such cases. What you told is right, sir. Especially there are several rheumatological conditions which are throwing up more than what we expect them in the usual way. So one should not jump the gun and take. I only appeal to our esteemed learned physician colleagues. First dose, second dose, unofficial third dose, booster dose. America visit fifth dose. I think enough is enough.
No, obviously, because of this reason, actually, there is a hesitancy to take the so-called fourth dose here. Locally in Guntur, we are not exactly jumping to take the fourth dose. We all took the third dose, of course, as I said, in 21 September itself, but not now. None of us are really jumping to take the fourth dose.
Until a vaccine which works on various variants, we have to use our mask only.
Yes, sir. Distance and mask when you are not in your biological bubble. If you are
Yes.
out of your biological bubble, use the barrier.
That is the only way at present.
Any postgraduate student who is interested to have discussion? Any other? Sir, Dr. IV Rao, sir, please, sir. Sir, unmute, sir. Unmute, sir.
No further questions, madam. Thank you.
Sir, Swami, sir.
Nothing, madam.
Shall we conclude or?
I think everyone has got vaccine fatigue.
Yeah.
In the agenda, we left out with things like updating our directory and upcoming conference at Vijayawada. Two things we will discuss on some other day, sir, with the executive committee, or shall we complete today?
Sir, I request IV Rao, sir, to kindly, we can think of tentative dates, sir.
For what,
From
madam?
Vijayawada.
Vijayawada, sir.
Usual dates, madam. We usually conduct in the month of September or October, no?
Yes, sir. Yes, sir. Yes, sir.
After the
Madam.
monsoon.
Sir, Manoj garu.
సార్ అదే మామూలుగా ఎలాగో మనం ఇప్పుడు ఏలూరులో కలుస్తాం కదా సార్, ఏలూరులో ఒక హాఫ్ అన్ అవర్ ఇదివరకు మనం ఉన్నప్పుడు పెడదాం సార్.
We can discuss. Yes.
అలాగే.
ఏలూరులో
అలాగే.
జస్ట్ అందరూ
Certainly.
ఉంటాం కాబట్టి
Yeah.
అలాగే.
And
ఏలూరులో
we can also discuss about the CMA programs and all that.
Sure, sir.
సీఎంఏ
Sure, sir.
మేడంతో కోఆర్డినేట్ చేసిన తర్వాత మీకు ఒకసారి ఒక రోజు పెట్టుకుందాం సార్, అన్ని రెడీ చేసిన తర్వాత.
Yes, sir. Yes, sir.
Postgraduate programs. Sir. Before the next.
మార్నింగ్ విత్ ఇన్ 1 వీక్ 10 days లో అంతా సెట్ చేసిన తర్వాత మీకు ఒక రోజు ఇన్ఫార్మ్ చేసి ఒక హాఫ్ అన్ అవర్ కూర్చొని రెడీ చేస్తాం.
అలాగే.
Yeah.
అలాగే.
రిగార్డింగ్ ఫర్దర్ ఈ 2 points కి మనం అక్కడ ఏలూరులో కూర్చుందాం సార్ ఆఫ్టర్నూన్.
That's very nice,
Yes.
sir. Okay, sir.
Okay, sir. Sir, thank you very much, sir. Thanks to Siddheshwari madam for accepting to host the midterm conference of APA. So we'll go on to the date as assured that it's not the March 5th. So we have to go with the March 12th. March 12th.
Yes, sir.
Okay, madam. We'll be in touch with you and we are all there with you. Sir, thank you, sir. Thanks to Dr. Alladi Mohan, sir, Dr. Harikrishna Garu for being with us today. And I thank each and every doctor, Dr. Ivy Rao sir, chief pattern, the mentor and guide and the driving force for all of us, Dr. Ramnamurthy sir, Dr. Prabhakar sir, Dr. M.B.R. Sharma sir, Dr. Swami sir, and Dr. Kiran. I think we are doing both of us silent work, and still we have to do a lot. And I thank executive members for joining us today. And I think though the number is few, we got the best. Thank you very much for being with us. And I request Dr. Manoj sir and Dr. Uday sir, Prabhakar sir, to select for the next month good speaker from your area, sir. Already Kiran completed, and from Zone 3 this completed. So February, I request the vice chairman of all the 3 zones to kindly select good speakers and new topics, and as and when needed, definitely will give opportunity to all the young generation. Thank you very much, sir. Good night.
And I also thank Video Technologies for their back-end support, and I thank one and every all of us for successful enlightening program. Thank you, sir. Thank you and good night.
Good night, sir. Good
Thanks,
night, sir.
and
Good night,
thank you
sir.
very much.
Namaste.
Namaste, sir. Namaste, sir.